Welcome back to the DNA of Things, where today we are exploring an incredibly fascinating topic, the shift from sick care to healthcare, and how scientific wellness is paving the way for this transformation. We're joined by Dr. Nathan Price, a visionary in the field of personalized medicine and digital twins, to discuss the seismic shifts needed to foster work-life fusion and manage our health and energy more effectively. We'll also venture into the realm of transition reversal, the role of digital twins in health optimization, and how personalized medicine can prevent diseases before they even occur. Get ready to uncover the potential of genetics, behavioral education, and how these elements are integral to crafting precision health strategies that cater uniquely to you. Let's dive in. Dr. Nathan Price, it is a pleasure to have you here, the man behind the vision, the co-author behind the vision of the scientific age, the age of scientific wellness. So here we are, my copy. Why the future of medicine is personalized, predictive, data-rich, and in your hands as the listener. And so, before I introduce you, Dr. Nathan Price, I wanted to read the forward of this book because it's quite compelling, for the listener's point of view, because there's an important P word in here, and I'll spoiler alert, it's participatory, but I want to run through this in context. So this book advocates scientific wellness via healthcare that is predictive, preventative, personalized, and participatory. So there's that word again, participatory. So we, the authors, dedicate this book to all those who will help solve the very challenging fourth P. So that's the participatory. So achieving this requires so much more than our efforts alone. We must persuade partners across all aspects of healthcare ecosystem of the life-changing path before us. We wish you success in optimizing your own journey and hope you will join us in ushering in the age of scientific wellness. Now, it is an age of scientific wellness, and, just for the audience's benefit, the folks who have, let's say, endorsed your book include people like, David Sinclair, the author of Lifespan, who we know is on the cutting edge of longevity research. There's the maverick, George Church, professor of genetics at Harvard Medical School, founder of, a plethora of health tech startups. So
18 in 1 year alone at one point.
18 in 1 year. There you go. And then you got, you're co-authored on this with Leroy Hood, MD, PhD, who's no schlub, founder of Arival. Am I saying that right?
Aravel.
Arival. And he's a legend. Give me like 30 seconds on Leroy.
Yeah. So Lee was named, I think, in Scientific American a little while ago as one of the top 10 most prominent living people in biotechnology. So Lee is very well known for many things. One, he invented automated DNA sequencing that made the human genome possible. He was the co-discoverer of the MHC complex, which is central to your adaptive immunity. He got the Lasker Prize for that, shared with Tonegawa. He won the National Medal of Science. He's considered broadly the father of systems biology and one of the fathers of personalized medicine in that field, founder of the Institute for Systems Biology. And he's founded, I think it's 18 or 19 now, companies. He had a founding role. He played a big role in the founding of Amgen, which was obviously one of the biggest. EPO, which was their first big product, was licensed out of his lab. He was a co-founder of Applied Biotechnologies that did all the genome sequencing, et cetera, et cetera. So Lee's really had a legendary career in biotechnology.
So he's kind of a big deal.
Oh yeah, absolutely. He's a big deal in science, and also translating out to university, out to industry. So yeah, Lee's had a remarkable career.
Right. And so for the benefit of the listeners, that provides better context for your bio, because this is what Lee has to say about you. So this is outlined nicely in the book. Which again, if folks who are joining us haven't read this, which I highly recommend they do. A little bit about Nathan Price, who's joining us here today, who I had the pleasure of meeting. What did we meet in Vegas about 3 months ago at the Health 2.0 conference?
Yep.
Just impromptu conversation, very unassuming gentleman on a speaker's panel. And we got into some conversation about precision medicine, And then I went home and I did some research and I found that, we had similar networks through, Thorn, et cetera. I dove into your book and so learned more about you as stated here by Leroy Hood. So Nathan Price, who is almost 40 years my junior, is an expert in the intersection of big data with biology and medicine. Graduate student, he built computer models of the vast repertoire of biochemistry and living systems in an effort to answer questions like how does your body convert the food you eat into energy and all the components needed for your body to function. These are heady times. The human genome and other genomes had been sequenced, and it was possible for the first time to build comprehensive maps of biochemistry with a catalog of how enzyme coding genes actually were. So Nathan thrived at the Paulson's lab, where he felt he could wake up every morning and ask, what is the most valuable thing that I can do to advance science? Now, there's pages here of Nathan's accolades. I want to skip to, I think, what's particularly relevant to our call today. And, besides the academic credibility that Nathan brings, there's the industry advancement that he was able to achieve, becoming the CEO of Longevity, a health artificial intelligence startup, which later followed an IPO, and he became the chief scientific officer at Thorn Health Tech as a result of that acquisition. You published more than 1,100 peer-reviewed journal articles. And well, frankly, you're just doing a lot of really exciting things at Thorn now, as we were talking about, and I'm sure we're going to cover some of them. So with that intro, I'd like to actually start with what I call the problem statement of the book, at least to me. I mean, you tell me if I've missed something there. But yeah, what compelled me was this notion of let's call it the sick care playbook. So, that's the legacy systems that we live in now. So where the sick care rather than healthcare, where in today's world, medical interventions happen long after a disease has taken hold, following a century-old medical playbook that goes like this. 1, wait for something to go wrong. 2, identify the cause of the problem. 3, try to fix it. And 4, if it works, try the same approach on the next person. And 5, if it doesn't work, treat the complications or write the death certificate and move along. It sounds quite distressing when I read it out loud because I was only reading it in my head before. So, okay, well, fine. That's a problem. All right. But what I love that you've done is just on the very next page is you've introduced this idea. Well, that's where we are today, the healthcare of tomorrow, right? So we've got this trajectory of, we start in wellness, and then there's this kind of transition where we're not so well. And by the way, we can dive into defining wellness as you see fit. But what you've got on these timelines, figure 1.1 of the book is this transition reversal, right? So let's talk a little bit about that, because I see that as, well, before you got the disease, like we haven't been tracking towards this disease, but there are some early signs and symptoms that we can track in on. And I think that comes back to, well, this age of scientific wellness that we're in with as it relates to the data rich and predictive. So I'll pause there and maybe you can just shed some light on this whole idea of transition reversal.
Yeah, it's one of the areas that we're focused on so much because on so many diseases, if you wait until after illness, like we often do, the ability to make changes can be very small. One example of that is Alzheimer's disease. So if you wait until a bunch of your neurons and your synapses have died and they're gone, there's very little chance that you're going to be able to, through a small molecule drug or any other type of intervention, not only regrow those neurons, but connect them in the ways that they were connected, right? There's billions and billions of interconnections that have been lost, depending on how far you are in that disease. But if you're thinking about transition, now what you're talking about is, all right, I want to keep those neurons alive. And there's all kinds of things that you can do in order to push off dementia into the future. And those can be relatively simple. One is you want to keep oxygenation to your brain. So exercise makes a big difference. There are certain supplements that matter. Phosphatidylcholine becomes rate limiting to the production of energy under low oxygen conditions as you get older. So that's a supplement that can be helpful. Vitamin D plays a role in the regulation of reverse cholesterol transport pathways, and also in protection from certain infectious insults. That can be protective in terms of your brain. You can go down, you're keeping your chronic inflammation low, et cetera, et cetera. And so what we really get into when you think about transition is we want to understand the early signs of what happens before you get into a crisis situation, many of which you can measure and you can reverse. And that's true in Alzheimer's, it's true in diabetes, it's true in, anyway, you go down the line, but it's true in many cases. We want to expand the science behind that dramatically so that we can get it, kind of these pre-disease states for all the diseases that we know of, and paths that we can get reversal early on before you get into trouble.
Yeah. So that's really, to me, the thing that's, most fascinating in terms of these windows for transition reversal. I'm just pulling up a conversation note that I had with Brandon Larson just the other day, who pretty amazing individual. He's done work in the past with Red Bull high performance teams, consults with NASA, a real kind of systems biology guy in terms of solution finding. And one of the things that we were talking about is, well, exactly this, these transitions so we just talked about transition reversal. There's also this notion of, well, transition optimization. So one of the examples was your bone density status at age 12 is a pretty good predictor of your risk of developing osteoporosis or osteoarthritis later on in life. And so then the idea is, okay, well, what can you do, in those developmental years to maximize bone density loading? And, of course, I think there's a ton of other things that permeate from just that conversation. Like if I, spoiler alert, jump to the end of the book, really what we're talking about is the actionability, which, right. So figure 11, 12, where 10% of it's healthcare in terms of your optimal, health, wellness, performance, let's say 30% genetics and 60% behavioral environment. So my question to you is, we've got the emerging biomarkers, and, you've given me some, initial, call it wellness, transitional reversal solutions, various vitamins, minerals, supplements. What is it that we can start to do on a, call it behavioral education side of things with this new system of big data? And maybe just for better framing, let's frame this with the systems biology approach. So this idea of, well, what is systems biology and how does that apply to me? How does that apply to like me insofar as how I am a community of cells that develops over time throughout age? So what's good for me at age 6 or 12 is not the same as 30. So how does this become the new playbook for, parents, for example, helping their kids recognize their individuality, so to speak? Yeah. What are your thoughts there?
It's a great question. So there's many ways that we can start to leverage like big data to try to understand the best things that we can do for our health. And just to get it out there, since I'm not going to spend a lot of time on it, there's obviously central aspects that make a big difference to everyone's health, right? Maintaining your muscle mass as you get older. Otherwise you lose 3 to 8% of it per decade. Getting your VO2 max up, right? So you have oxygenation, keeping well exercised, a good diet, all those table stakes things make a massive difference. So the way that kind of some of the more modern tools that we have can play into this, let's just talk about one to start with, like genetics. So one of the things that we've been able to show is that, so we had taken thousands of people through a wellness program. This is one back when we were running Aravail, and we generated a huge amount of data to learn from. And one question was, let's just take one biomarker that a lot of people use, LDL cholesterol, been used for a long time. It's often, the trigger for getting prescribed a statin, which millions of people are on, these kind of things. So one question was, could you lower LDL cholesterol by lifestyle intervention? And so we looked in our data, and like a bunch of previous studies found, we found that, yeah, you kind of could. Sometimes it went down, sometimes it didn't. And you got this sort of modest effect. But when you start layering genetic information in there, what we found is that, no, that's not really the full story. What it turned out is that the genetics would predict a subset of people who would be able to lower their LDL cholesterol very substantially by lifestyle, and other people who could not. And the difference was that you can actually predict the amount, you can predict your LDL cholesterol from just your genome. So if I don't know anything about your diet or your lifestyle, nothing, you could capture a fair amount of that variance. And so what we did is we created a genetic prediction for LDL cholesterol, or we used one. And basically then what you do is you look at the actual value in someone's blood and the level that's predicted genetically. If there's a big gap, you can change it. And if there's not, then you can't. And so what that says is that the genome, so just imagine, so that's true for LDL cholesterol. It's true if you're trying to raise your HDL cholesterol, the so-called good cholesterol. It's true if you're trying to lower your hemoglobin A1C, prediabetes and diabetes marker. And so what you could do is you can actually put that across hundreds of different markers. And then rank order them from largest gap to smallest gap between your genetic prediction and the actual. And what that does is it gives you a personal map to all of the things in your health that are most likely to change for you. And you can put aside the things that are unlikely to change. Now, you may actually want to change those for other reasons, and that might get you into pharmaceutical areas or something like that, but they're not going to change very easily. And so the other thing you can do is in your genetics, because you can also use these polygenic scores, this is summing up lots of little pieces of information on DNA, and it gives you a risk for all these different diseases. So then you can start to build a map that's like everything that you're super at risk for and against all the things that you know are the easiest to change. And so you can triangulate on and say, all right, what's the next thing I should do? Well, I should look at the things that I'm at most risk for that I can most change, because that is where I will get the absolute best bang for my buck in terms of, effort invested or whatever to modify the course of your health. And so you're just trying to take a lot of that future risk and eliminate as much of it as you possibly can. And that gives you a personalized map. So that's what didn't exist before. So there's all kinds of good things, but now you can say what's malleable, what's not as malleable, and prioritize.
I mean,
so that's just one. We'll go on a bunch of other things, but just starting with genetics.
Well, I mean, yeah, I think in what you just said is there's an infinite number of plans potentially based on the variation of the individual. And so what it makes me think of actually is a decathlete, right? So if you get a bunch of decathletes lined up, they've got 10 events. What you're measuring at the end of the day is their total score, right? And so you sum up, how they perform across all the events. Now, so there's a 100-meter sprint, there's a 110 hurdle, there's long jump, high jump, pole vault, there's a 1,500-meter run, there's all the throws. So you can see, just given that the outcome you're looking for is maximum score, right? Just like in life, we're looking for maximum health span, which I want you to help me define, or maximum wellness. So basically what you're saying is like, you can kind of take a personalized approach like a decathlete would to maximizing your score. So I may be, let's say you and me are competing. I may be a great, let's say, natural speed. I'm going to say I'm a natural speed athlete, right? So I'm really good at the sprints, and that lends itself to me being above average in the throws. The jumps, I'm okay, but less so. And my endurance is just shoddy, so I'm going to score around 7,000 points. If you and I were going to race in the 100, I would run a 10.5 and you would run an 11 flat, let's just say, because you're on the endurance side, right? So that's a magnitude of difference. Half a second in the 100 is massive, right? But now you've got me beat on the endurance side on the 1,500, So, and your pole vault's better because you're lighter, and your plyometrics are more efficient, so you're jumping me. And so I guess the thing is, like, the thing to correct on is not that we're not competing against each other for wellness, but we are playing our own game in terms of finding our own precision plans. Because actually that was one thing that you reminded me of in the book. Sorry, you probably know exactly where I'm going.
As you're looking for that, I think one really interesting thing as well is if we're talking about athletic performance or something like that, we probably want to optimize whatever we're best at, right? Because you're like, here's my comparative advantage, like you do in your career. And here's what I'm really good at. I'm going to try to drive that. Health is actually kind of the opposite. because
Interesting.
at least if you're thinking about longevity or maximizing health span, because it's the weak link. Like we all, very sadly know people, who might be really, we had a person in Airville that was like this, super fit, great on lots of measures, except got pancreatic cancer, right? And
Right.
that was the end. Pancreatic cancer, one of the very worst cancers you can get. And
Right.
so it is this kind of interesting flip because you want to find out what are, you want to have the highest, the longest, weakest link you possibly can, right? You want to push that out,
Hmm.
to that degree. And so it is a little bit different when you think about, optimizing athletic performance versus say
Hmm.
longevity. And sometimes
Right.
those things are actually a little bit at odds. Interesting.
Right. Right. And so, yeah, that's what I was harkening back to is the imprecision medicine. Right.
Mm,
So,
yeah.
and so here's where I'll venture that the analogy was more similar in terms of the decathlon in sport and the decathlon in health is there's no blanket solution. Like I couldn't give 10,000 individuals the same decathlon plan and expect them to all score the same.
Oh,
And because there are some, really compelling statements here, in insofar as, at best, 10 of the highest grossing drugs prescribed in the United States help no more than 1 in 4 patients. Some help as few as 1 in 25. And so that's like you talked about genetics. That's a whole additional layer of understanding around pharmacogenetics.
yeah. And that's was really eye opening. And that comes out of a paper in Nature written by a Nick Shork, who's a
Hmm.
colleague down at UCSD. But it really is pretty shocking when people get into this because you run the clinical trials and we have all these guidelines, that are evidence based, which is great, but they are aimed at the average of what happened in a population, right? Which
Right.
sometimes is as good as we can do, and we're trying to get beyond that. But it does lead to this era of imprecision medicine, as we point out in the book, because the number needed to treat in order to get a positive benefit for the patient is large, as was pointed out there. And so it's not and so this is why there's such a push towards precision medicine, right? The notion of the right and under precision medicine, it takes a little more of a narrowed view than we do, but they're trying to get, the right drug to the right patient at the right time, which is
Hmm.
an admirable pursuit. What we go farther with scientific wellness, and another name for scientific wellness is really precision health.
Okay.
And the notion of that is really taking those same approaches that are used in precision medicine, but now moving them much earlier to say, can we do precision prevention? Can we do precision optimization of your health? And a lot of what comes into that then is to understand in detail what's going on in your particular physiology and how do we make it so that the vast majority of people are responders to what's happening in health. And this is an area we'll get into more later, but you can
Hmm.
really build sophisticated models around this now, even digital twins that will help you to answer that question for a person.
Hmm. Okay. So yeah, you took the question right out of my brain. I'm itching to get into that topic of digital twins. Maybe before we go into like what digital twins are, like how did you get there? I mean, I gave a little background on where you came from, like your accolades, but like how does, Nathan the boy grow up to be Nathan the scientist inventing this initiative, digital twins?
Yeah. So I first got into this area. I guess we could go back when I got into graduate school, I became very interested in systems biology and in particularly computational modeling of the body. And
And
so
what is systems biology, just for the listeners?
so systems biology is an approach. Well, let me back up. So if you think about molecular biology, so molecular biology tries to study the body and you basically break down what's going on in disease or health down to its constituent proteins and metabolites these molecules. So it's very, so molecular biology.
Hmm.
Systems biology is sort of what you do next, which is I have all these molecules and all these pieces. How do I put them together so that as an emergent system, they give you life, right? They give you all the processes of your body. So molecular biology would figure out, oh, there's an enzyme that converts glucose into glucose 6 phosphate. Systems biology will take that as one piece of information. Oh, here's an enzyme that makes glucose into glucose 6 phosphate. And then there are thousands of others of these. We put them all together and we then simulate, okay, how do all these things interact together such that I can eat a sandwich and turn it into my body,
Right.
right?
Right.
And derive energy from it so that I can live. And so systems biology is just that holistic view of what's happening.
Mm-hmm. Mm-hmm. Okay. So systems biology captivates you. Then what?
Yeah. So systems biology, very interesting. And that leads to computer models, obviously, because there's too much complexity in biology. You can't wrap your head around all of it. You've got to build
Mm-hmm.
models.
Mm-hmm.
So I became very interested in that. I ended up taking a faculty position at the University of Illinois in Urbana-Champaign in chemical engineering in their Institute for Genomic Biology, but then deferring it for 2 years to go work as a postdoc with Lee Hood, who we talked about before. Lee was a hero of mine in science, and I wanted to go learn from him. His story was famous, and I had, tracked his career for a little while. Got to go and spend 2 years there. Went back to Illinois, built out my own research group that was building, again, computer models, but now for a couple of different areas, one of which was personalized medicine, so systems biology aimed at medical problems. Lee recruited me back to ISB as an associate professor 4 years later. And so I moved back, then became associate director for the Institute. And we ended up, starting all the companies and various things that we did. But basically, so the way that I progressed through this then was to understand first metabolic models, which is what I started with. And then you get into areas of regulatory networks and how genes interact to control more of those processes. Got very involved in and very interested in scientific wellness, right? The subject of the book. And then as you start progressing, part of the digital twins, which we'll get into in a moment, but you're trying to do a fuller representation of what's happening in the body.
Mm-hmm.
And that's partly made possible just by the advances that the whole field is making, right? We have so much more data. We have so much more compute power. AIs are better. Everything that we're doing is better. And then the last part of that was really connecting with someone who's become really a good friend and colleague over the years, Tom Patterson, who I talk about in the book, who had gone through a similar trajectory, was the co-founder of one of the early companies in quantitative systems pharmacology called Entelos. And, we got talking, we talked for several hours about the notion of, coming from this aspect of scientific wellness, we're trying to understand homeostasis, like how does the body maintain health? And how do we map that out? And what are the processes and how do we do that? And he had been coming at it from a little more of a top-down, dynamic models, feedback loops, and so forth. And I was coming at it more from this like really dense molecular level detail from multi-omics data. We thought, hey, if we could, and Tom came to me and we were talking, said, hey, if we could merge these things together under this kind of paradigm, this should be pretty transformative to understanding disease processes and how we could intervene for prevention. And so we teamed up on brain health and Alzheimer's disease about 3 years ago. And that's how we've really built this out. And so from my standpoint, that has been, one of the great collaborations of my life for sure. And it is something that, we're really pushing out because we want to get these into the hands of physicians and helping patients and all of these kind of things, because I think they're going to be really revolutionary.
So what is like the future application of digital twins? Well, I should say, where is it today and what's the future application of it? So how is this going to presumably help me with that transition reversal opportunity that we talked about before?
Yeah. So first of all, the way to think about a digital twin, right, is it's a computer representation of your biology. So it's
so I'm in the meta. You've taken me in the meta with my biology.
That's right.
Yeah.
In the meta.
Yeah.
And I will say, I don't think we're anywhere close to a full digital twin. I'll say that. So like even when I talk about digital twins, and I'll give some examples, the one we've built is for brain health. And
Hmm.
I think there'll be other ones that will be built for metabolic health or skin health or aging or whatever.
Yep.
I
Yep.
don't think we're quite there to where we can build a full representation of a human, either in
Hmm.
terms of computation or data. So I
Hmm.
think it's going to be piece by piece for a while.
Hmm.
Now, in terms of
Hmm.
what's out there right now, there's not much.
Hmm.
There's not much. I actually went to write a review paper on digital twins, or at least I was exploring writing one, I don't know, 6 months ago or something, and all I could find were other people talking about, with their opinion pieces about about what was happening. There's not a lot out there, although I think that's starting to change. There's the work that we've done at Thorn. We actually have a functioning, great version of a brain health digital twin model. I love showing it to people when they're skeptical of whether these things, where they're at. So that exists. There are other
Hmm.
companies out there that are progressing in this space as well. So I think we'll start to see more of those. So the
Hmm.
kind of things that you can do with it, though. So I'll just give the example, just to be concrete. I'll just talk about the brain health and what it does.
Hmm.
So you can take information in the form of blood measures,
Hmm.
and there's many modifiable risk factors for Alzheimer's disease, and that's one of the things to really keep in mind. Well, I gave that example at the beginning, right? Which
Sure.
is
Yep.
you know treatment, trying to reverse late stage Alzheimer's. No one has a clue how to do that, including myself.
Hmm.
And but prevention, different ballgame.
Hmm.
So as we think about, so what the digital twin model would do is we could have, say, so a person comes in, and the model it's an ordinary differential equation model. So it's dynamic. So it has feedback loops, and it adjusts to, changes in environment and conditions. And it has what's called a Bayesian network layer on top of it. And so I don't, we don't have to get super detailed, but the one thing that people should understand about Bayesian is that it adjusts to priors, or it will adjust to however much or how little information we have. So in other words, if I have a digital twin, this physiologic simulator, and I just leave it, and I know nothing about you except you're a human, it will compute the average trajectory for a human. But as soon as I say you're a man, it changes.
Right.
And then I say you have these levels in the blood, your hemoglobin A1C. Let's say you were pre-diabetic and you've been that for this long, and you're 50 years old, and your ApoE4, which is one of the really important genes. You have one copy of ApoE4 and one copy of ApoE3. Every little piece of information you put into there, it adjusts accordingly. And so as you start putting in enough information, it starts being more and more specific to you. And so as you do that, it becomes a better and better version of a digital twin. Now, what can we do with that? So given that information, it will predict, one, the most likely age of onset for dementia. Now, and it will have error bars associated with it. There's all kinds of uncertainty in these things. And so we account for that. So you get a distribution. Uh, so one figure that I show often is a 50-year-old man, and we predict for him that his likely age of onset is 61. There's all kind of factors that go into that. He's sleeping terribly, has low vitamin D. There's a number of factors, but and then there's a distribution. But with 98+% probability, he will have dementia at before age 69. So it is, so you get that in that start. Now you should think about that a little bit like the ghost of Christmas future, right? If these shadows remain unchanged, because what you're saying is that the other thing that it does that's more important is it will then simulate all kinds of intervention strategies, and how many years of benefit, how far into the future could you push that dementia diagnosis? Again, based on data from 1,000 different papers and a rigorous simulation of brain physiology. And so when you do that, what it will say is you'll take an individual intervention, and some of these things are quite simple, right? Vitamin D, phosphatidylcholine, exercise, increase your sleep, change some aspects of your diet. There are all kinds of things we can get into. And it will then say, what percentile of a responder do we think they are? Are they in the bottom of the population, or are they at the very top? And then you get the number of years of benefit. Now, one really interesting thing that comes out of this is, for most people, most single interventions don't do anything. They don't move it at all because it's a systems problem. There's usually a few things that you have to fix at the same time. But when you do combinations, almost everybody is predicted to be a responder. So I'm on a little bit of a crusade right now because almost every clinical trial for prevention is based on testing a single compound, which almost never work. And so we actually create in this industry a sense that a lot of these things don't hold up, but it's partly, and I just gave a talk on this to the advisory council for the NIH director, and I'm going to give one of the 3 opening keynotes on Alzheimer's and multi combination therapies for the NIH here in about 3 weeks. So, I'm really trying to push this out right now, but it makes no sense for us to pin so much about what we're doing in prevention around single compound trials when the digital twins teach us that almost everyone is a non-responder. So it pushes you into this space where you have to run trials on tons and tons of people because you're waiting for sheer dumb luck to find the person that one thing is the final piece. And it's almost never true. And the thing that kills this, especially in the natural product space, is if you're not talking about a multi-billion-dollar drug, there's no economic return at all for running the scale of trial that you would have to run. Because, if you run $1 billion trial to prove that vitamin D works, anyone can sell that stuff and it's $5, right? Like you'll never get that back.
It's one way to burn $1 billion. Yeah.
It's a way to, yeah. You saw that like really old show, Brewster's Millions. Remember when he has to do, this would be the kind of thing that he would have to do, right? This for the young people, there's a guy that has to spend $30 million in a month in order to get his true inheritance, and he has to burn money as fast as possible without telling people. This would be one way, right? You could run run trials that you could never get a return on, I suppose.
Right.
So that becomes really important though, because we have to structure evidence, or what I like to call personalized evidence-based medicine, because you can set up these trials so that they're tests of the digital twin model, which represents a detailed understanding and a comprehensive, rigorous model of what you believe is happening in the disease, such that every single person in the trial, right, their data hits the same algorithm, and you do something different for every one of them. But what we show is that the effect size is predicted to be much higher. And so the N you need is much lower, and you get valid results in a reasonable period of time at the kind of investment that makes sense. And so that we think is going to change so much about the field, but you're not testing whether the compound works. You're actually testing, is a personalized solution based on the digital twin, does that work? So you're testing the algorithm. And I think that's the really big shift we have to make.
Wow. There's a lot there that just went in that riff. Let me see if I can pull a couple of things out. Yeah. Thank you so much for that explanation. Love the journey, man. It really does come back to, what it says, what Lee says about you at the beginning of the book is like, how can I wake up today and contribute the most to science? And what a profound, would you say counterintuitive? I mean, when you explain it the way that you'd explain it, it's not counterintuitive at all. It just makes a ton of sense, but it's counterintuitive, I'd say, based on how we might be educated and how conventional trials are done. It's interesting because I hear you say, basically kicking out your predisposition or your date of certainty to develop dementia, let's say, but maybe you kick it out indefinitely. That's a real cool thing. The other interesting thing, so let's even back up before that, the idea of, what you described with the Bayesian models as an example, essentially what we've got is a heuristic that's a rule of thumb that gets better than a rule of thumb as we start to add more data to you based on your experiences in terms of the intervention strategy. And what I'm trying to compare that to is, well, look, these biohackers out there that basically do trial and error, and then they find their little cocktail that works and call it vitamin D or call it cod liver oil or call it the ketogenic diet or whatever. It's like, no, you've tried a bunch of different things and you kind of got lucky in terms of this cognitive boosting formula that you've got yourself. And then, that's the other end of the drug industry spectrum is like, oh, well, here's the supplement or nutraceutical proprietary blend type solutions, which the interesting thing is like, we're kind of, I think if we could meet in the middle, it's a really exciting space because this even goes back to what you were talking about with systems biology, because really what we're talking about is synergy.
Yeah,
Talking about
I
the
lost
whole.
the audio for about the last 20 seconds.
Oh shoot, am I back?
You're back. You're back. But just
Okay.
if you asked me a question, I don't know what it was.
No, I think I was trying to re-explain what you said to see if I understood it, and it's effectively getting at the point of there's the nutraceutical industry and the pharmaceutical industry. They're both kind of doing different things.
Yep.
Nutraceutical kind of seems they're got single compounds, except when you get into these proprietary blends, right? Which might be good for a few people, but until you've got the comparison, you understand all the other different data inputs, you understand the response capability of these different interventions, you're not going to go too far. When I think about the entrepreneurs that I work with who are particularly motivated to sharpen their cognitive ability, to me, it seems like this digital twins framework is awesome. I mean, this is actually what I hear quite often in terms of a performance goal from entrepreneurs that I work with is like, hey, I want to perform as good or better cognitively until I'm 120, if possible. And so it sounds to me, it's like this digital twin brain model, well, as far as I can tell, is the best way to do that in a way that's evidence-based, based on your individual data.
Yeah, it's definitely going to give people a deep insight into that.
Mm-hmm. Mm-hmm.
I will say I love biohackers, and yeah, pay attention to your body. And if you're finding something that's like crushing it for you, absolutely, keep doing those things. It does make visible some of the things that are really hard to see, though. I'll give an example. So some of the things that you can get into when you get into data. So in the digital twin model, as I mentioned, under low oxygen conditions, which you think is one of the big triggers, and your oxygenation in your brain goes down as you get older. It's one of the reasons you get Alzheimer's when you're old and not when you're young.
Mm-hmm.
But one compound that becomes rate limiting for a lot of people is phosphatidylcholine.
Right.
And so people who eat diets rich in phosphatidylcholine, you get it in eggs or you can supplement with it. But if you have diets rich in phosphatidylcholine, on average in observational studies, they get Alzheimer's at 3 years later. And we have a mechanistic explanation for that. And like I said, the model predicts it becomes rate limiting. So it's, anyway, that's how we triangulate on that. Now, here's where it gets more complicated, though. So if you're now looking in your microbiome, right, and Thorne has a microbiome test that we do. And so we've done this on many, many people. But one issue is that if you have certain bacteria in your gut, some of those bacteria will eat phosphatidylcholine. So you could be taking phosphatidylcholine, either dietary or supplement or whatever, but phosphatidylcholine is coming in. Those bacteria will eat phosphatidylcholine and they'll turn it into a different compound called trimethylamine, which your liver then turns into TMAO. TMAO is a risk factor for cardiovascular disease. So you could literally be trying to optimize your brain, and instead you cause yourself. Now, there are ways you can get around that. Get tested for TMAO every once in a while. Make sure it's not. So so if you're working with a physician, or if you've got a good measurement that you can do online, we've got some pretty comprehensive blood measures. If people are interested in them, you can do those kind of things and just watch for it. But that's the kind of thing that would be really hard to tell, because if you asked either of us to say, what's your TMAO level in your blood by just how you feel, I don't think you can do that. We could run a randomized controlled trial, I guess, and find out, but I'd be surprised. And there's many things like that. Another example, your hippocampus. So you can lose in your brain. So if you can lose about half of your hippocampus before you start having measurable cognitive deficits, right? Stuff that you would notice. But if you're doing imaging, for example, you might be able to tell, whoa, this thing is shrinking faster than it should. Well, I better be looking at, how do I stop that, right? How do I build that back up, et cetera? So there's all kinds of things that I think you can get into that are hard to see in the short term. Vitamin D is another example. Short-term randomized clinical trials don't show benefit for vitamin D for dementias. And we actually evaluated that because this is why vitamin D is actually, I'll just give you an example here. So in observational studies, published hazard ratio for that in one population was 0.23, meaning people low in vitamin D are 4 times as likely to get Alzheimer's as people who have sufficient vitamin D. That's a huge difference. Now, in the randomized controlled trials, they did the vitamin D doesn't come up as being significant or meaningful. Therefore, in the official recommendations, vitamin D is not included as a way to prevent Alzheimer's. And I write about this in an LA Times piece that I did a few months ago. It's not included.
Hmm.
But one of the cool things with the digital twin model is we can go back and simulate those clinical trials exactly, right? We can simulate the age of the patients that come in, how long they were tracked for, and we do that under the assumption that vitamin D has exactly what the effect size is seen in the observational study and is 100% causal because we actually know the mechanism.
Mm-hmm.
And when we do that and we rerun those trials, what it says is that if vitamin D is absolutely as causal as it appears, we would expect none of those clinical trials to show a positive result because it's for too short of a time. It's
Mm-hmm.
too short of a time, and it's in the wrong age window because the curves are actually quite close in certain age windows. They only start diverging later. And so when you're looking at the number of people that are diagnosed from, at high and low vitamin D.
Mm-hmm.
Anyway, all of that is a background to say that, okay, you're doing things that you feel like, okay, I'm optimizing, I'm feeling it, but there's many things that are beneficial that you can't tell the difference over a couple of weeks or a couple of months or even a year. And that's what the digital twins kind of make visible are, all right, here are things that are going to have a benefit over the long run. And it's
Mm-hmm.
very hard for us as humans to prioritize that,
Mm-hmm.
right? It's why people smoke or eat sweets or do whatever, because the benefit of the cupcake now is immediate. And it's like,
Mm-hmm.
oh, okay, it's going to add something to some vague future. Like, who cares? Right. So
Mm-hmm.
that's how we're wired, just in our
Mm-hmm.
the behavior. And
Mm-hmm.
so it is important that we focus on things that we can feel in the short term because that's motivational to us. But I just
Mm-hmm.
want to point out that what data can do sometimes is show us things that if we make them a habit, they will pay off big benefits in the long run, even when we can't always feel them. So our feeling. And one more brief aside, I don't that I just remembered I hadn't talked about this in a while. There's a guy named Larry Smarr, a good friend. He was the head of the San Diego Supercomputing Center and one of the world's first really big quantitative self guys, measured everything about himself. And he
Mm-hmm.
actually did an experiment over, I forget how long he did it. I think it was at least a year. I think it might have been several years. But he was measuring elements out of his blood and stool, tons of measurements all the
Yeah.
time.
Yeah.
And he was recording on a daily basis how he felt.
Yeah.
And the strong conclusion was that his health as measured by biomarkers and his feelings were almost uncorrelated. Now, there's some different, there'd obviously be some things at the edges, but
Mm-hmm.
it was very interesting, like how little that he was able to feel when he went into transitions that led him to like irritable inflammatory bowel disease and things like this. How uncorrelated, how much the markers said something was happening so much before he started feeling anything. So he's actually done that in a level that very few have, at that level.
Was he based out of Boston at some point in time?
Maybe way back before he ran the supercomputing center at the University of Illinois, and then he moved and ran the supercomputing center in San Diego. Those are the two places that I know. If he was at Boston before then, I'm unaware of.
I'm sure I heard him speak before because back in my microbiome days, he was like the guy who was sampling himself every day. I'm sure that was him.
That's right.
Yeah.
Yeah. There's another guy in Boston that does that. Eric Alm at MIT has measured his own microbiome very frequently.
Mm-hmm.
Both of those do.
Mm-hmm.
Those two
Mm-hmm.
and Mike Snyder at Stanford are kind of the three people we point to the most as like the first pioneering,
Mm-hmm.
N of one, measuring
Right.
themselves in great detail people.
So quick question on the cognitive models that you have. So are those up and operational at Thorne? Are you doing research there? Or is that something that you offer as a product today?
We don't offer it as a product yet. We are willing to do this, in research collaborations with people, and we are doing that.
Right.
It's something that we are actively developing. I would love to get this out as a product, hopefully next year,
Mm-hmm.
because it is operational. Like, if we work with doctors or something, like we can take data and generate these and generate the distributions, the recommendation, like it's all built, like it all works, all functional.
Right.
We're just need to productize it, and get it out there in a robust way.
So,
And I
so
also need to evaluate what, exactly how we get it out from the regulatory standpoint. And,
Sure,
there's
sure.
probably ways that we, can't get into. It'll probably go out as a brain health model, right? And not get into the dementia aspects. We'll have to go through FDA for that and things of that
Right,
nature.
right. But if I had, say, a forward-thinking, innovative entrepreneur, money is no object, and they're willing to pursue this from like a research angle, there's some collaboration to be had with Thorne in terms of
Yeah.
helping that entrepreneur. Is that right? Yeah. Okay. And so
Yeah, no,
today,
we're definitely actively pursuing ways that we might, if
mhm,
we could do this
mhm,
with various partners. So if there are people that are interested, if it makes
mhm,
sense, we'd love to do it. And and my big passion here is this Alzheimer's and dementia is an absolute scourge. It's a $500 billion a year
mhm,
problem, which is
mhm,
trending towards $1 trillion a year problem by
mhm.
2050.
Right.
And
Yeah.
that's the least of it, right? I mean, there's on surveys, you know, Alzheimer's and cancer are the two most feared diseases in the world and most people would say the disease they least want to get is
Mhm.
Alzheimer's
Yeah.
because of, and one of the chapters in the book is
The long goodbye.
Long Goodbye, right? Which is
Mhm.
Lee's chapter about his wife who's
That's right.
lost her mind to Alzheimer's, and it's been over the course of 18 years or so now. I think. I mean, it's
Yeah.
about it's about that, and and that is a long time to watch the woman you love not remember your name and not be able to do anything else, and it's a horrible disease. We'd love to put an end to it. I'll tell you that.
Listen, I know that we don't have very much time left for our call today. I knew when I booked this call that it wasn't enough time. It's like we could talk for 6 hours, I'm sure. But I wanted to give you the floor just on the path forward, the 7 challenges. I'll just name them quickly, and just to you to riff on where you think the low hanging fruit is in terms of help and synergies. Keeping in mind that people listening might be one of the collaborators that offer those solutions. So the 7 challenges I'll just quickly run through is, how can we include everyone in this vision of wellness? We just talked about, hey, well, we might be able to, help somebody who is, let's just say, has the financial wherewithal for their precision cognitive preventative slash optimization protocol. But how do we then use that to get it to everybody? How can we validate new actionable possibilities? How can we persuade payers to assume the cost of wellness and prevention? These aren't small problems. How do we decrease the cost of phenomic analyses, all these complex data that you're talking about? How will we bring wellness and prevention to healthcare systems and eventually to all individuals? How do we assure this form of healthcare is available to everyone? And finally, how do we solve the 4 major challenges of contemporary healthcare: poor quality, aging populations, exploding chronic disease, and unsustainable cost escalation? So I just point those as things that obviously you can't solve all those on your own, Nate. Yeah,
Right at the
right.
end
But
of the
yeah, in the last 10 minutes, please give me the way forward here. But given that this is, such, call it an uphill battle, what's the keystone? What's the thing that we can all unite around and kind of rally toward, the optimization of these outcomes? But maybe just starting with, what can we take personal responsibility for?
Yeah. So there's a number of paths into this, I think. One is the one that you ended with, which is the responsibility each of us has for our personal health, and that
Mhm,
the tools that are available now, we've never had better tools than we have now.
mhm,
And so you can get access to a lot of information. The AIs that have come in on board too allow you to delve into the science and basis behind things at a level that wasn't possible before. I mean, even things like the more advanced versions of ChatGPT or others that are trained specifically on medical literature are pretty staggering in the ability to get descriptions of processes that you're interested at the level that you can understand them. Right. So you might go in there, right? I'll go on there and I'll say, like, treat me. I have a PhD in whatever. And, sometimes I want it to write a real detailed something. But if it's an area I don't know about, it's like, okay, explain it to me in lay terms. Or if you wanted something for a child, you can tell it to write it for a third grader or whatever. And it's not 100%, either are humans for that matter. but but that is pretty amazing. So the ability to start owning a deeper understanding of your own health, I think is incredible. And and going to experts and getting expert advice when when that's warranted. But you can get a long way in terms of really educating yourself these days. I think that's really important. Uh, the second big pillar, and probably the most important, is making all of this economical in the world, and that and making it viable. And this was one of the reasons that I ended up taking the job at Thorne, and moving from ISB as my primary home, even though I loved it there so much, is because I think there's so much complexity, right? And we talked about a little bit of that along the way. We have to be able to take the burden of complexity off of people. You have to be able to give them simple things that they can do, that they can fit into the course of their life while they're just living their life, right? And so so that's partly the digital twin algorithms and things like that, is that we want to be able to deal with that complexity algorithmically so that you can benefit from that complex understanding, but in simple ways. And then the economic piece is really critical. And one of the real struggles that we have now, if you're in a country where you have, like, where the government, let's say, is paying for all, taxes are paying for all health insurance, or things of that nature, it's a little easier to align incentives, because if you're the government, you actually benefit from all the aspects of prevention. Healthcare costs goes down. That means there's more tax revenue to spend on other things. Your population's healthier, that's more productive. So there's more money in the system, et cetera. So those incentives can line up pretty well. In the fractured system that we have, it's pretty challenging, because insurance companies will generally tell you they only care if you can make a cost benefit for them within 3 years. Some of them even say they only care within 1 year, because then you're going to switch policies or whatever. I feel like it's incredibly short-sighted, because everyone that switches off of your policy is going to your competitors, and all of them are coming to you. So as an industry, it feels like it should still be worthwhile. But anyway, that's aside for now. But that's the argument you'll get in almost every case. And so, and we also have these odd incentives in the healthcare system where we don't require drugs or new therapies to be cost negative. We pay for therapies, but prevention programs almost universally are required to show that they save money. Now, ideally, yeah, that's what you want to do. But it sets up this really weird dynamic where we value economically years of sick life very highly, and we don't value years of healthy life at all. We don't, because again, we don't want to pay for them. We want them to cost negative dollars. And that's not a burden placed on therapeutics. So so one of the ways that I think we got to get out of this is through aligning how we pay for healthcare, which goes into, so it's insurance, but it's really who owns these risk contracts, right? Underneath the insurance business. So who owns the risk for paying for populations these days? And you can imagine optimizing health associated with those kind of payments and showing that you can lower the cost for populations reproducibly. And so finding an economic model whereby you can address health and prevention under a model that can benefit economically is going to be important for these things to really scale. And you can be kind of utopian and say, well, it doesn't matter, and all we care about is health, and that's fine. And it's really easy to do, especially in academic days. It's very easy to do, and advocate for that and be all for it. But the odds that will actually scale and make a difference in the lives of millions and millions of people, it's just not likely. You've got to have a way that this makes sense economically in the world, or it's not going to scale and persist over years and decades. And that was one of the things we ran into with Aravel, honestly, right? Which is, it was an amazing program. We showed that people improved their biological age markedly, their health got better. The data that came out of it led to incredible discoveries. We talked about a few of them, tons of papers, fabulous, but we didn't solve the economic model there. And so it died, and all those great benefits went away. And so that's the real issue that I think is the central piece of all of this. And when you're talking about healthcare, it's getting up close to a fifth of the economy, right? As it's growing up, it's like at 18+% now. And it's been, growing faster than inflation for decades. And so when you look at that, the amount of effort and challenge to shift even a small fraction of that size of an effort is radical. And so it is going to take way more than me and Lee, and way more than Thorne, and way more than, than any of us, because the scale of that endeavor is massive. Now, one thing I will say is that when we first started this, there was tons of pushback, and tons of people told us like it's not even worthwhile, to go down this path, because it didn't fit into the the usual way of thinking from the disease standpoint. That's not so true anymore. There's so many people that think this way and that are pushing and driving new companies and building new areas. And I wrote a Scientific American article last December, I think it was, on this emerging wellness industry that's coming out, and highlighted, I think, 40 or 50 companies in there. Like, there's a scale of effort that's ramping up that's really pushing this. And in the book, we actually point to this Deloitte report, where they think that, I think it's, that wellness will be about the size of healthcare, of disease care, I should say, within, I think it was either I think they pegged 2040 as that period. And so there's more of these groups that are kind of coming online with this. And so it's becoming a movement that I think that's large enough to, start to make a difference. It's still tiny compared to the disease care industry, but it is growing rapidly.
Amazing. I could dive into another, hour of dialogue just on that topic. But you know what? I think it's a nice return back to how we started the dialogue, which is, participatory. So that is, people being personally responsible for their health, but also participating in the greater, initiative. And, a lot of entrepreneurs will be listening to this. And, I think about your systems biology models, and it's like, well, really, we're talking about a systems model for economics, where we can actually start to think about how all these wellness and healthcare solutions are actually, you put them together and they're much more than the sum of their parts. And the way that we're perhaps measuring them now is maybe analogous to, how we've been doing drug trials. And we need, to kind of look at that economic model through a new lens, at least as it relates to the preventative versus reactive healthcare, such that we can get as a priority these transitional reversals, and maybe even preventing them from happening at all in the future, especially when we have tools like, for example, your digital twin. But listen, let me pause there, because I know that you've been super generous with your time, and I know you have another appointment to get to. Nathan, where can people get in touch with you? What's the best way for them to find you?
Yeah. So best way to follow me, LinkedIn. I'm quite active there for people that want to get updates on kind of the latest. I post there quite often. Also on Twitter, which is at ISB Nathan Price. So if people want to connect there, and then, products and things that we build in this space are coming out from Thorne. That's thorne.com, thorne.com. And generally happy to connect with people that have interesting things that they want to do.
Awesome. Well, I'll put all of your information in the chat and on the publication side of things, connection to all those resources that you mentioned, and also a link to your book. So again, The Age of Scientific Wellness: Why the Future of Medicine is Personalized, Predictive, Data Rich, and in Your Hands. Dr. Nathan Price, thank you so much for being so generous with your time.
Thank you, Jeremy. Great to be with you.
All right. What an enlightening journey we've had today on the DNA of things. Dr. Nathan Price's insights have truly illuminated the path to a future where health is proactive, personalized, and predictive. We've navigated the challenges of merging work-life elements, the importance of managing our energy and health, and the groundbreaking concept of transition reversal. The potential of digital twins in healthcare has been a beacon of hope for a world where diseases like dementia can be predicted and prevented. As we wrap up, let's remember that the shift towards scientific wellness isn't just a possibility, it's a necessity. Aligning economic initiatives, validating new health paradigms, and ensuring everyone has access to personalized, evidence-based medicine are steps we must take together. Thank you for joining us, and let's continue to shape a future where health and wellness are at the forefront of our collective journey. We'll see you next time.